Good morning and good evening, everyone. I'm glad to see so many of you here today for this webinar on the roadmap to endemic COVID-19, shaping policy and planning in Singapore and the United States. This webinar is jointly hosted by the Salisbury Hawk School of Public Health at the National University of Singapore and the Duquesne University in Pittsburgh, United States. My name is Liang. I serve as Vice Dean of Global Health at the School of Public Health in Singapore, and I'll be the moderator today. I have a few announcements before we start. First, of course, this webinar is recorded and will be made available at our respective university websites. Secondly, if you have any questions during the talks later, and we do encourage questions, please type them into the Q&A box, which I'm sure most, if not all of you, are familiar with now after 2 years of Zoom. Finally, Dean Akinzi of Duquesne University will not be able to join us today. We are privileged that Professor Bridget Calhoun will deliver a talk in his place. Let's start with the opening addresses. First up is Professor Ying Teo, Dean of the Salisbury Hawk School of Public Health at NUS. Dean Teo, please.
Thank you very much, Liang. So good morning to our audience from Singapore and Asia, and good evening to our audience from America. And definitely a good afternoon to anyone joining us from other parts in the Pacific. It's a real pleasure for me to deliver the opening remarks to the inaugural webinar jointly hosted by the School of Public Health over at the National University of Singapore with Duquesne University in the United States. I think to really share some of our experiences in how the work that we're doing in academia have been able to influence and maybe even shape some of the public policies for COVID-19 in Singapore and in the United States. Overall, I believe all of us are very familiar with the situation in COVID-19 now, that there is a general sense of optimism, including those that are voiced by Dr. Anthony Fauci, as well as just as recent as yesterday by Dr. Hans Kluge, the WHO Europe director, who said that Europe could be headed for a COVID-19 endgame. But equally, there was a word of caution by the DG of WHO, Dr. Tedros, not to assume that the rest of the world is able to head towards an endgame strategy with Omicron being the last variant. But I think since the start of the pandemic, I personally am of the opinion that the global scientific response by many researchers and scientists have been one that is remarkable and outstanding, whether it is in devising new ways to diagnose COVID-19. If we just think about our antigen rapid test kits now, we have really transformed a laboratory into a test kit that we can use at home by you and me, by average people who are not familiar with actually how the science works. We've seen the development of vaccines and even now the therapeutics for treating, especially also a lot of innovations that happen in the digital space, where we think about contact tracing, we think about communications that are now able to move beyond the manual approach. That's the scientific response. But what was rather disappointing instead was actually the political response in some of the jurisdiction. And when I think about the societal response, I think it's fair to say that it has been inspirational in some jurisdiction and yet at the same time chaotic and divisive in many other countries and jurisdiction. So it really highlights the importance that the response from us in academia must go beyond simply a health or clinical sciences response, but to really look at the multiple disciplines that are needed to address a crisis. It could be the legal and the ethics, the social, the behavioral sciences, the engineering sciences as well. Because I believe at the end of the day, when we start to think about how well people keep to the use of non-pharmaceutical interventions, like social distancing, like mask wearing, or even how well they receive and accept effective vaccines, fundamentally depends on how individuals perceive, how individuals behave. So it is never just a technological or scientific response, but equally the social science, the behavioral sciences are just as important. And when we think about those aspects, I believe that the bit about building up trust and partnership prior to the start of any global crisis really has to happen before the crisis strikes. And this is really what we're doing today as well. Having this webinar together with Duquesne University, bringing two partners from two parts of the world, coming together, learning from each other. because I do believe that COVID-19 is not the only crisis that will impact the world, and it's actually not the only crisis that's happening right now. If we just think about antimicrobial resistance, climate, environmental impact, these are just simply two ongoing crises. And clearly, if I also extend it to the wave of non-communicable diseases such as diabetes, hypertension, and stroke, as well as cardiovascular diseases, especially with many societies facing the increasing burden of aging populations, you will realize that actually moving forward, there are a lot of problems that the world continue to face, and yet there is a degree of disdain that the world treat many of these issues, just as how the world started looking at COVID-19 with a lot of disdain in the beginning. So today's webinar really marks the first time our two institutions, the National University of Singapore and Duquesne University, come together to really look at what the future holds for us in the United States and in Singapore, at least for the next 6 to 12 months with respect to COVID-19. Now, especially when the world collectively starts shifting from a pandemic response towards an endemic response, it's useful to really get a sense of what does this actually mean. And today, that's where I really look forward to our mutual sharing from my colleagues in Singapore, as well as our colleagues from the United States in Duquesne University. So with this, I look forward to the conversations that we will have, as well as also the opportunity to future partnerships between our two institutions. So with that, over back to you, Liang, and thank you very much again.
Thanks very much, Dean Teo, for highlighting the major things for this pandemic and for reminding us that there are public health issues of great importance that have been neglected because of this pandemic as well. Next, we have Professor Faunelinkov, who is the Department Chair of the Rango School of Health Sciences at Duquesne University. Professor Linkov, please.
Dear friends, before starting the seminar, I was thinking, should I say good morning or good night, because we are connecting from such different time zones. And then I thought, if I say dear friends, it's going to unite all of us into one umbrella, and I'm not going to have to think about the time of the day. So I wanted to welcome all of you to the seminar called Roadmap to Endemic COVID-19, Shaping Policy and Planning in Singapore and the US. And despite the challenges of COVID-19 pandemic in the past 2 years, one good thing that came out of this is our ability to conduct things remotely. So this seminar is a perfect proof how we can be so far and yet so near each other in this desire to connect and desire to share our academic and scientific experiences and to conduct research and academic partnerships remotely. And the first thing I want to do is to thank the organizers of the seminar in Singapore, especially Elisa Coati, who has been on multiple emails with us, trying to organize everything and trying to make sure that everything goes smoothly. So I wanted to thank everybody one more time for such an amazing opportunity. So my name is Faunelinkov, and I'm an epidemiologist. Over the past 2 years as an epidemiologist, I was absolutely amazed. When I did my training in epidemiology, I learned that it took, say, 20 years to develop a vaccine for polio. And here I am in 2022, witnessing how it only took basically 10 to 11 months to develop an effective vaccine for COVID-19. And yet, as Professor Teo just mentioned, even though we had the amazing scientific ability to develop this vaccine so fast in today's society, the political response has not necessarily been there. So today we have an opportunity to discuss, like, what is it that was done correctly? What is it that could be done better next time? And how can we move forward together to establish a partnership to hopefully help resolve all those amazing issues? So in addition to being an epidemiologist, I'm an associate professor and the chair of the Department of Health Administration and Public Health at Rango School of Health Sciences at Duquesne University. Just a few words about Duquesne. It's a private university in Pittsburgh, Pennsylvania, United States. We have a beautiful campus tucked sort of on the side of Pittsburgh downtown, which is absolutely amazing. We have over 9,000 students at Duquesne. And our faculty today who will be presenting in the seminar represent Rango School of Health Sciences. And Rango School houses programs like public health, health administration, physician assistant studies, and many others. What attracted me to Duquesne about 2 years ago when I joined this amazing school is the ability to start new international collaborations. And we are working with many different countries, and we're interested in joint partnerships and setting up programs like 2+2, 2+3, so students from both of our institutions could learn from each other and could take advantage of spending time on both campuses, for example, here in Pittsburgh and also in Singapore. Today, I wanted to introduce my colleagues, Dr. Drtrell, Calhoun, and Kanijahani, who will be talking about some of the things that we have been doing at Duquesne in response to the pandemic. In this program, we'll be sharing our institutional, national, and also local research experiences in relation to COVID-19. And thankfully, we'll have time at the end of this seminar to brainstorm about some of the questions that the participants may have about this program. Myself, in the past several months, I have been looking at several issues related to COVID-19, and that especially related to communications around COVID-19 pandemic. We found that the communications have not been optimal, especially some people mentioned Dr. Fauci. Unfortunately, some of the communications coming from US government and the CDC have not been optimal. So hopefully together we can do something to move all those things in the right direction. I hope this seminar will be a great start to research and educational collaborations between our institutions. And I wanted to welcome students and faculty members from all around the world to visit us in Pittsburgh and to share your experiences. Welcome. And I want to pass the floor to Dr. Drtrell.
Thank you very much, Professor Linkov, for the very nice address and for the introduction to the Rango School of Health Sciences at Duquesne. I'm sure many of us are just about dying here in Singapore to go to the US and to visit you properly. And next up, but not least, we have Dr. Mark Cantrell, who is the Director of Public Health at the Rango School of Health Sciences as well. Dr. Cantrell.
Thank you very much, and please do come visit us. So for me, it's really a privilege and an honor to join you all in this webinar. I'd like to thank the organizers, our colleagues in Singapore, and all of the participants for this tremendous opportunity. So as was mentioned, my name is Dr. Mark Cantrell. I'm the Director of Public Health here in Duquesne University. And I'm also the former COVID-19 country coordinator for United Nations in Nicaragua. So while the majority of the webinar will focus more on the experiences of Singapore and the United States, I wanted to offer a brief reflection on the global progress made in addressing the pandemic and really some of the ideas or some of the things it's going to take to end the pandemic. To date, more than 9.8 billion doses of COVID-19 vaccine have been given around the world, which has literally saved millions of lives and prevented severe illness and countless others. In addition, clinical treatment has vastly improved since the beginning of the pandemic, and the world now has new therapeutics that are both effective and reducing morbidity and mortality. However, inequitable access to vaccines and therapeutics between and within countries have led to unnecessary illness and death among the world's most vulnerable countries and communities. Indeed, while we see some countries are fortunate enough to widely offer even booster doses, others still struggle to access and administer even the first vaccine dose to their vulnerable populations. And we still have countries that are in the single digits when it comes to population vaccination rates. Not only does this lack of access directly threaten the health of less resourced countries and communities, but it also creates the kind of conditions favorable to the development of additional variants like we're seeing with Omicron. Omicron continues to circulate widely, setting infection records throughout the world. While this variant appears to produce less severe illness, it is still responsible for a high number of hospitalizations and death, particularly where vaccination rates are low. If this unchecked viral transmission is both tragic and worrisome, and the longer it continues, the higher the risk that the SARS-CoV-2 virus will change in unpredictable and potentially dangerous ways, as was seen with the more virulent Delta variant. Fortunately, there is hope. Humanity has demonstrated time and again its capacity to quickly organize and address shared problems. In the case of ending the pandemic, this must include an equitable approach, ensuring that everyone, everywhere, has access to the proven tools in ending this pandemic. Therefore, I'd like to conclude to encourage you all to support global calls like the call led by the World Health Organization for all countries to work together to increase vaccine access and reach the target of vaccinating 70% of all people in all countries by the middle of 2022. In the case of Singapore and the United States, we are particularly influential countries with both the technical, financial, and political resources to answer this global call. And I hope you all are able to play your part. Thank you, and best wishes to all.
Thank you very much, Dr. Cantrell, and for reminding us about the greater picture, the global picture. Many of us here in Singapore, and I'm sure in the US, do mostly navel gazing and worry about the things in our own backyard, and don't count ourselves fortunate compared to what's going on in many parts of the world, or how we can reach out to help them. And now we move on to the webinar proper. We will start with Professor Bridget Calhoun, who is Associate Dean for Academic Affairs and Research at the Rango School of Health Sciences. Professor Calhoun earned a doctoral degree in infectious diseases and microbiology at the University of Pittsburgh, and she has been a national leader in physician assistance education with a record of over 20 years. Her main area of research is in HIV and AIDS, supporting the Pittsburgh sites of the multi-center AIDS cohort study. And she'll talk to us about the institutional response to COVID-19 at Duquesne University. Over to you, Professor Calhoun.
Thank you so much. And I'd like to echo the welcome, the warm welcome given by my colleagues. We're all very happy to be here. Unfortunately, Dina Kinsey is not able to be with us tonight, so I'm standing in on his behalf. I'm going to share my slides, but before I do, I just want to highlight the beautiful image of our campus that Dr. Linkov has as her background. And I would love to say it looks like that today, but it's really covered in about 6 to 9 inches of snow that we've gotten over the past few days. So when you all plan your visit, please plan it in the spring and summer when it's not covered in snow as it is today. I'm just confirming you can see my slides. Yes, thank you. So I will focus today's talk really on the logistics of how our university, much like other universities here in the US and around the world, have really been able to sustain the educational process despite the fact that we were in an international pandemic. And during this time, it was particularly challenging because the needs of the university and the questions and uncertainty of the university were very different than the uncertainties and some of the questions related to the students, which I will highlight here shortly. So as you already heard from Dr. Linkov's welcome, our university is in an urban setting. We are a private university that spans about 49 acres. We have a student enrollment of about 9,000 undergraduate or total students, which also represents about 5,400 undergraduate students. And in March of 2020, much like the rest of the US, we had a significant disruption in the academic process that we were delivering. And the initial belief was that we would do a temporary transition to online instruction that would last approximately 2 weeks. Well, as we all know, that story changed dramatically, and those 2 weeks went into months, and those months have now progressed into years. But what some of the logistical challenges were from universities like ours was to very quickly make that transition to online instruction with faculty members who may have had no experience with online teaching or some kind of intermediary experience with online teaching, and of course, some who were full-on instructors from the get-go. As those students were very swiftly moved off of campus, we had to evacuate essentially 3,500 students while trying to maintain social distancing. And as you can see in the the image behind Dr. Linkoff, our buildings, because we're in an urban setting, you know, we had to minimize how many people were on the elevator at the same time or in the stairwells. So just the sheer fact and challenge of mobilizing students out of their dormitories and living quarters was really the start of what we would be dealing with for here now 2 years later. Our university transitioned more than 1,000 courses to fully online, which really required many collective efforts of our colleagues working in computer and technology to make sure that not only were the faculty equipped to deliver such instruction, but that their course materials were also able to be mobilized that way. I'll highlight here soon that we in the School of Health Sciences had some very unique challenges because of the laboratory-based courses and some of the clinical-based courses that many of our students were enrolled in at the time. So the training for faculty was fairly intense. Many faculty members had to have some of their initial and basic instructions. As we all know now, we're quite all savvy and really have perfected the world of Zoom. But this was really challenging, particularly in courses where we may have enrollment of 60, 70, 80, or 100 plus students. And there was concern that we may lose some of the engagement that students would participate in during this time. So much of the training at Duquesne University and universities like ours was in teaching professors how to maintain the level of engagement with students as we progress through with delivering our courses remotely. When faculty had to return to campus, we had to maintain the safety and security of all times. In fact, when any of us wanted to visit campus or return to our offices to either retrieve items that we needed for the educational process, or much in our examples, collect lab supplies that were then shipped to student homes, we had to be granted permission from our superiors so that we would be permitted on campus. We had to provide information about why we were there, what we were retrieving, what our expected time on campus would be. And then, of course, we're required to adhere to all of the recommendations at the time, which included social distancing and mask wearing. The students who were taking traditional courses were probably the ones who were most or who had the most ease of transition, simply because of the learner-teacher format that was quite traditional in some of their classes. Where we and universities like ours ran into the largest challenges were with some of our laboratory-based courses. I use the example of our cadaver lab because it is utilized by 5 of the 7 departments within our School of Health Sciences, and really the very quick suspension of the laboratory courses made us really have to show resilience and creativity on how we can do this. Thankfully, there were many resources online that we could use to augment the traditional lecture and substitute for the cadaveric dissection. And here's just an example of that. What proved to be the most challenging were the clinical courses. And I know there are folks in attendance tonight who can sympathize with this, because many of the hospitals in our area had to fully suspend clinical rotations, or in some cases totally abort them and not allow students back into those clinical settings, not only for concern of the students themselves, but also for the patient population for whom they were serving. When we had clinical environments that were allowing students to return and to maintain their path of education, many times the university was required to provide those students with their own personal protective equipment. So the time at the university was a very foreign one to us, because we had very few people on campus, but yet we were still delivering our traditional based courses, our laboratory based courses with some alternatives and some augmented learning, and then our clinical based courses, which required in some cases the suspension or reassigning students to different environments. One of the things that Duquesne University, I think, did exceptionally well was relying on those of us who were in the schools of health sciences, nursing, and pharmacy who have had formal public health training, so that we could demonstrate some leadership in this unique situation, but also collaborate with one another, not only in sharing resources and knowledge, but also coming up with a plan for how we would not have to completely halt what we do for a living and halt the educational process. In our area, the University of Pittsburgh Medical Center is a huge academic health system that allowed the placement of many of our clinical students. And so the leadership from Duquesne University worked very carefully and deliberately with leaders from the University of Pittsburgh Medical Center to develop a joint protocol, which was designed to gradually allow students back into clinical environments, and also outlined what requirements there were. At the time, it was things like quarantining if they were returning from a different state, or what type of personal protective equipment would be provided by the university and what would be provided by the institution or the healthcare facility. Throughout the summer of 2020, Duquesne University remained fully operational, but heavily reliant on our remote technology. Many of our clinical programs, we were mailing lab supplies to students' homes, and we were asking students to videotape themselves performing things like suturing or on anatomic models, or allowing them to demonstrate their physical exam skills on either family members or others with whom they were living. At this time, the university also decided to continue the policy to calculate final course grades as a pass-fail option without using the traditional letter grades. So I hope you can appreciate that the logistics of this far exceeded the just reliance on computers to deliver our educational programs. It involved logistics of folks coming to campus, being evacuated from campus, but now also the grading scales that were used for our students. At this time, we also had very deliberate conversations and working meetings with our local officials. Our public health officials at the state, local, and national level were relied upon heavily, and many conversations were happening. We were asking for expertise and information from local hospitals, not only about the COVID patient census, but also about what protocols are being put into place so that we could inform our students about what to expect as they were going there for their clinical placements. We collaborated very aggressively with some of the other universities in our area to see what policies were being developed, what best practices were, and how they intended on keeping the student population, the faculty population, and the staff population once the university reopened in the fall semester. So the establishment of best practices, and also in some cases, some shared resources. There was a point early on in the pandemic where we within the academic units were donating some of our supplies to local hospitals, particularly some of the smaller hospitals that didn't appear to have enough of their personal protective equipment for their staff. So this was really a time of sharing best practices, sharing resources, sharing knowledge, and ensuring that the safety and security of everyone was in first position. So the master plan was developed by the university in preparation for the academic 2020-21 year. And this included input from the varieties of offices that you can see here, but also the establishment of various task forces, plural, that would address the unique needs of these activities across campus. So for example, in addition to learning spaces such as traditional classrooms and laboratories, there also had to be consideration for how students would be served their food, or how they would minimize contact with one another within the dormitories. So these task forces were designed and recruited by the university president to then develop a plan for safety and security for when the students would return to resume as much as possible of their academic training. The master plan had some guiding principles of safety, mission, continuity, and flexibility. And I think this really demonstrated some forward thinking, realizing that what was decided in the summer of 2020 may have to be adapted and finessed a little bit as we worked our way through the pandemic. Now, throughout the establishment of the master plan and the logistics, there was always a priority placed on providing students, faculty, and staff with the appropriate personal protective equipment. We wanted to make sure there was appropriate availability of testing on campus, and many times those testing sites were manned or worked by university volunteers. And so we were able to mobilize our entire university community to help make sure that safety and security remained a priority. We also wanted to be sure to physically distance infected students from the rest of the herd, and also quarantine facilities for people who were exposed. Now, I already mentioned the physical location of our campus is in an urban setting, so the university contracted with local hotels who at the time had very low census and used those hotels as points of quarantine, so that when students were believed to be exposed on campus or at their home, they were removed from campus and put into this temporary housing. And then ultimately, the master plan allowed for us to prioritize the vaccine administration for those most vulnerable on campus, as well as for those of us who are healthcare providers naturally. Now, the master plan, oh, I have a repeat here. So the master plan really worked with these principles, and you can appreciate this, that we wanted to make sure we stayed with the mission of the university to serve students, so that we really didn't want to be an industry that had to fully suspend all of our operations. We wanted to ensure continuity of our operations so that students could progress towards their degrees, and particularly for the ones with whom we worked, knowing that they would join the healthcare workforce, who at the time was very much in need of more folks. Unfortunately, for many of our students, their graduations were delayed as they were trying to make up some lost hours of clinical time. And also, we were obligated to notify many of our accrediting bodies, particularly the specialty accreditors, to let them know what modifications were made within individual academic programs. Now, in terms of human resources, the university also decided to establish some task force specific for the health and safety protocols that were being developed. We worked to be sure that we were in compliance with local, state, and federal guidelines, and continued to work diligently to establish best practices and share that information with our colleagues throughout the city and throughout our state. We also established pandemic officers for every building. And this was at least initially unique to Duquesne University, although this has been adopted more widely since this time. But these individuals were challenged to anticipate the unique needs within their physical buildings once students returned to campus. And so there were questions like, how do we distance folks when two people are trying to use the same microscope? Or how do we offer sections of labs when we had to minimize the number of people in a particular space? For those of us who work in the human simulation lab, running students through simulations, what has changed in the capacity of those lab-based physical spaces? And so we wanted to optimize learning, but also keep people safe in unique ways based on these learning spaces. Now, in terms of our school-specific continuity plans, here, those of us in the School of Health Sciences were also asked to anticipate what some of the student questions were. And many times it was related to their timeline for finishing their academic programs, but also would any adjustments in their graduation impact their ability to sit for their national certifying exams? And so a lot of work behind the scenes that was really non-traditional in the day-to-day operations of those of us working in academia at the time. Now, in terms of the clinical programs, we had some real challenges because we wanted to continue the progression for enrolled students and with appropriate modifications in classroom and lab areas, but also with experiential learning and those going out on rotations. And then we were matriculating new students at the same time. So this required incredible balance and forethought and incredible planning. The university ultimately went to testing on campus using volunteers from the university community, which proved very efficient and very easy. Although there were some of the volunteers who were not healthcare providers, so we had to do some additional training for them to get them ready for that. The university also established a COVID-19 dashboard, which really facilitated communication in a very transparent and timely way so that the entire university community was aware of how many people were being tested, the number of positive tests, how many confirmed cases there were on campus, and then were able to make their own comparisons for our university community, but also that within the city and within the state and within this region of the United States. And as I already mentioned, mentioned, those suspected cases were removed from campus to try to maintain safe numbers and safety here on campus. Ultimately, we developed vaccine clinics on campus. Initially, the vaccines were administered by students and faculty in the School of Pharmacy. And just like the rest of the world, as continues today in some parts, priority was given to those who are most vulnerable with comorbidities and those working in healthcare. One of the best things that came out from the university perspective of this pandemic was the establishment of a community-based vaccine clinic. This was a partnership between our university and our local health department, in which we were able to administer over 1,000 vaccines in an urban setting at a local church. And the vaccines here were administered by students in the schools of nursing, pharmacy, and health sciences, and really served in some cases as a substitute for some of their clinical training. In the fall 2020 semester, vaccines have been required for students to attend class, as well as faculty and staff working on campus. If a student or faculty member or staff member is not vaccinated, they are required to be tested weekly, and we are seeing good adherence to this. One of the things that we didn't fully anticipate was some of the mental health challenges that has been the result of this pandemic. And this is not unique to the university community, and certainly not unique to higher education, but we are starting to see higher rates of faculty, staff, and student burnout. And so we've had to expand some of the mental health offerings and counseling services available on campus. Finally, I'll mention some of the positive aspects that have come out of this, which deal a lot with the adaptation and resilience of our faculty and our students. We have seen some really creative adaptation for teaching. As I already mentioned, things like sending lab supplies to the students and having them videotape themselves using them. We've also utilized additional technology, as you can see here on my image, but we've also developed skill sets that we're seeing in students that we didn't really prioritize in the past, such as the opportunities for telehealth and telemedicine and remote internships. So we're trying to focus on some of these positives and to see what will be retained once the pandemic is over and we return back to normal practices, and what are things that we should keep so that we continue to further develop skill sets in students. We also have the possibility now that there may be expanded remote work opportunities for some staff members that we now realize don't have to physically be present on campus all of the time. And we are seeing some additional self-sufficiency of students. One of the examples that easily comes to mind is students now self-registering themselves or taking care of some of the administrative duties of keeping them enrolled at the university that were otherwise delegated to other people. Currently, we have 99% of our students and 93% of our full-time employees compliant with the university's vaccine policy. And so we remain encouraged for how the rest of this semester will go, and really feel that because of the university's diligence and because of the university's forward thinking, we've been able to maintain operations throughout this very challenging time. Thank you. I think I've gone a few minutes over, which I apologize for, but I will be happy to take questions as the webinar proceeds and as we get to the question and answer section.
Thanks very much, Professor Calhoun, for this reminder to us as well how we coped with the pandemic in NUS. It's a unifying time, but I'm not sure we really want to live through it again.
Right.
In the interest of time, we'll move on to the next speaker, who is Dr. Ahmad Khanijahani, also from the Rango School of Health Sciences. He has expertise in health disparities, social determinants of health, health economics, and policy. And aptly, he will speak about the racial, ethnic, and socio-economic disparities in COVID-19 infections and deaths in the United States. Dr. Khanijahani, over to you.
Oh, hello, everyone. Thank you for joining us today, and thank you for the opportunity to present and talk about our research. So I'll try to go over briefly the results from two of publications that we have done in the area of COVID-19 and health disparities. So before we begin, I am Ahmed Khanijani. I have a PhD in public affairs with a focus on health services management and research. And I'm also trained health economist. I'm board certified in public health, and I'm also certified health data analysis. So to give a big picture about health disparity, we need to focus on factors that impact health status or health outcomes. So as we know, one of these factors is having access to healthcare or medical care. But there are some other factors such as socioeconomic status, the society or the environment that the person lives there, any other demographic characteristics, and the decisions, specifically health-related decisions that we make. So these are the factors that at any given time can have short-term or long-term impact in health and longevity. So in terms of focusing on socioeconomic disparity, specifically focused on having access to main resources, we can have two scenarios. We have the person's initial health status at any given time. There are some factors that contribute to better health, classified as positive factors, and we can classify other factors as those that contribute to negative health outcome. For example, if you think about having access to insurance or having access to healthcare, being able to have certain level of physical activity or good diet or anything along that line, right? So those positive factors, they can contribute to better health, and this better health can create the opportunity for the person to work and generate more income, to put in simpler words. And at the same time, better health creates this opportunity for the person that this given person doesn't have or have very limited number of physical or mental conditions. In contrast, if you focus on negative factors, those will contribute to poor health, and this poor health, as a consequence, will not allow or very limit the person's ability to work, generate income. At the same time, there will be more or severe medical or mental conditions. So as you can see here, this cycle, both the positive or negative cycle repeats. So for example, in the first case, having better health, it will create opportunity that, for example, to have better income, and that better income will create the opportunity to spend more on health, spend more on better food and any other situation. At the same time, for example, let's focus on socioeconomic status. Having lower income or not having access to insurance will contribute to negative health outcomes, and this will cause not having enough resources to be able to take care of themselves. So in the first case, we have a vicious cycle. It's a good cycle that we want to have in place. But unfortunately, in the second case, this cycle will repeat, and the person and the health outcome will deteriorate as the time moves on. So just to simplify what we mean by health disparities in any given health outcome or health condition, we can think about the percentage of population on one axis and percentage of given health conditions or health outcome that we're talking about. So if there is no health disparities, the distribution will be along the blue line in the middle. So meaning that, for example, if you're talking about a good or positive health outcome or negative, doesn't matter. If it's there is no disparity, like for example, 30% of the population will have 30% of those conditions and so forth, right? So it means that there's an equal distribution of this bad or good health outcome. So we expect to see there is no disparities here, or there is very limited disparities. But as we move from this blue line here. In other cases, we can see disparities here. For example, if you look at this red curve here, we can say that 10% of population, if you're talking about, for example, a disease or a negative health condition, they have 35% of this condition. So meaning that we don't have equal distribution of this good or bad health outcome. Again, this is just a simple way of trying to see if potentially there is disparities or not. So I will try to go over quickly over our two researches that we have published initially based on county level. For those of you that might have joining from other places, the county is a geographic division, which is broader than a city. Usually they have rural or urban counties. So this is a county level analysis. We're trying to compare COVID-19 cases and COVID-19 mortalities per population, at the same time putting on the other side some socioeconomic and racial and other characteristics of the population at the county level. So in a nutshell, our first publication was analysis at the county level, similar to graph that I showed earlier. We see some disparities in terms of different characteristics of population. For example, in terms of race and ethnicity, if you focus on the distribution of COVID-19 cases in 100,000 county population or COVID-19 death in 100,000 county population, we see that there's a lot of disparities in terms of percentage of population being African American in both cases. So as you can see here, there is an unequal distribution of both COVID-19 cases and death. At the same time, we can see similar disparities in terms of resources, financial resources mainly. This indicator here, if you read the paper, it's trying to capture what percentage of households' income is used for household costs. So if that percentage is higher, it means that a lot of income, a lot of resources generated by the population or a household, it's get used to for expenses of the households. So in the second research, we tried to capture socioeconomic status by combination of different variables. So we used 5 different variables at the county level and tried to create one score for each county in terms of socioeconomic status. So these are 5 different variables for counties we used to generate this socioeconomic segregation, percentage of population below poverty level, percentage of household receiving any form of public assistance, percentage of female-headed households and unemployment rates, plus percentage of individuals older than 25 years who didn't have high schools, right? All of these are reported in rates and percentages. So we're trying to create a score based on this and define the socioeconomic status and also socioeconomic segregation at county level. The second part is racial segregation. And this one is basically trying to capture how much racial segregation is prevalent in this county. So for this one, if we included 25% or more of the residents were African American. So this analysis both include county and census tract. So census tract is a geographic unit within a county, and usually probably each county has more than maybe 100 census tracts. So the correlation between these characteristics that we included to capture this segregation is shown here, and we see that relatively high correlation between all of these factors that contribute to socioeconomic segregation. So this is the final findings from second research that mainly focused on socioeconomic and racial segregation, right? As you can see here in different models that we have explained in the paper, we can see that the counties with percentage of population, with high percentage of population living in concentrated disadvantage or being in socioeconomic segregation, or in counties with high percentage of population living in African American concentration or racial segregation, they had disproportionately higher COVID-19 mortalities. So if we put this together, meaning both focus on socioeconomic disadvantage, being in socioeconomically segregated county, or percentage of population residing in racially segregated census tracts. Again, these are percentage of county population residing or living in census tracts within the county. So as you can see here, if we have, for example, for a given county, with highest percentage of population living in segregated, racially segregated census tract, and highest percentage of population living in socioeconomically segregated census tract, we have higher predicted COVID-19 mortality. And on the opposite side here, if we have a lower percentage of population living in these areas, we have very low COVID-19 mortalities. We did also some sensitivity analysis, meaning that if we had different cutoff points to define different census tract and classify them as concentrated disadvantage or racially segregated census tract. In any of this cutoff point, for example, if we're saying top 50% or top 25% or top 10% census tracts, if we classified them as census tract with socioeconomic segregation, at any given scenario, we see that the relationship stays significant, and higher socioeconomic segregation and higher concentration of African Americans was associated with higher COVID-19 mortalities. So this was the first part. We're trying to show if disparities exist or not. But for the second part, the focus was more on what factors that can contribute or explain these differences. So we can focus on theoretically the factors that can facilitate the transmission or the factors that can decreases the chance of survival, right? The first one can increase the rates of infection and also mortality, and the second one is mainly focused on mortality. And also these factors can be defined as individual or family or household level, and also neighborhood level. So I will not go over it in details, but individual level, these are some factors that can explain the observed disparities. At neighborhood level, some neighborhood level variables and factors can distribute to disparities. So putting these things together, we should focus on policies and intervention that aim at mitigating both spread of COVID-19 and also policies that can decrease the mortality of infected individuals. And we need to factor in not only the individual characteristics, but also the neighborhood, either defined as census tract or any other forms. We need to factor in those neighborhood characteristics as well. And one-size-fits-all policies potentially will not be effective if we don't consider the different neighborhood characteristics as well. So these are 3 published research that I've included here. If you're interested to read more, you're welcome, and I will be happy to answer your questions. Thank you very much.
Thank Thank you very much, Dr. Khani Jahani, for sharing your work and for reminding us about how the pandemic has affected us unequally. Our next two speakers are from Singapore. First up is Dr. Hannah Clapham. She's a mathematical epidemiologist and formerly head of the mathematical modeling group at the Oxford University Clinical Research Unit in Vietnam before moving to Singapore. Her work on modeling and various aspects of the pandemic has informed our Ministry of Health and contributed significantly to policies developed to tackle the pandemic here in Singapore. She will speak on mathematical modeling to support the journey to COVID endemicity. The floor is yours, Hannah.
Hi everyone, thanks Liang for that introduction, and thanks to the previous speakers for really interesting insights. Okay, so today I'm going to talk about, as Liang said, the use of mathematical modeling to support the journey to COVID endemicity. And at the end, if you'll allow me, I'm going to get a little bit philosophical about what this means, but I hope it will fit in actually with the concrete things that we've heard so far about steps taken to ensure continuity and also understanding who is affected most by the pandemic. Okay, so I'm going to talk a little bit about modeling of COVID-19 with vaccination. I'm going to talk about uncertainty in that and how that's built into decision making and modeling and policy. And then I'm going to talk at the end about endemicity. So we'll hear a lot more about this from the next speaker, Dr. Mark Ho. But Singapore, like everywhere around the world, has gone through various stages of the pandemic, both in terms of transmission, control measures, and now most recently vaccination, which has been a large part of my work over the last year or so. So focusing on vaccinations, we had vaccines licensed in Singapore, a rollout, and we had the introduction of Delta, which led to a large wave, various changes in doses timing, boosters rolled out as we learned more about the vaccine and what was happening. And then, of course, most recently, the Omicron variant and how we've been having to deal with that. In response to this, and along with the decisions made about policy, we worked on building a mathematical model of COVID transmission. And I'll talk a little bit more about what we actually mean about mathematical modeling. But along the way in developing this, we started work on developing a COVID vaccine model before vaccines were out there, before they were available. So working sort of theoretical, if a vaccine does these various things, what does it do? Then we did various simulations of what would the rollout of a vaccination look like, and what would that mean in terms of transmission that would happen, and therefore other control measures that might need to be in place. We updated as lots of things changed, including the dosing. Once we got into our sort of transmission wave, we had to fit to the case and the data that was coming out of Singapore, and we've updated the model with boosters and then at different timings as we go along, and really looking at what, with all of these things within the model, what does transmission look like? What can we expect in terms of cases under different scenarios? And then, of course, most recently, we've updated this model with Omicron. And from my speaking with various modeling groups globally, the same kind of process has been going on around the world in order to kind of use modeling to understand what will happen in terms of transmission given vaccinations and given different control measures. And I say will, and I shouldn't say will. What are the possible outcomes given the vaccines and the control measures that are in place? So when I talk about a model, what I'm talking about is we're building a conceptual framework about how transmission is working. And here's a flow diagram. You don't need to be following it through, but just to say what we're doing is we're putting individuals in the population into their different groups, how they are in terms of susceptibility, whether that's changed great now due to vaccination or not, and how that looks in terms of their disease progression, as they move through, and the whole process of infection and the transmission process. And the reason why we need these kind of models is, of course, for infectious diseases, the fact that you're infected affects your neighbor, affects the people that you come into contact with. And so this ongoing process that we're modeling here, this model helps us go from that kind of individual process up to, okay, what will happen on a population level, given we try to control transmission, or given we have more people in our vaccinated groups. And then we put in the different vaccination strategies and the different control measures into this model. And our aim is that what we want to look at given the assumptions that we're making and given these control measures, what are the outcomes in the population? So what would we be thinking would be happening in terms of infections over time, cases, ICU prevalence, and deaths over time? So of course, when we're doing these kind of models, there's a huge amount of uncertainty. And I think when we're thinking about endemicity, we also have to really bring in the concept of uncertainty and how we think about this as we move forward. So of course, there's a huge amount of uncertainty with COVID-19. I just put a few examples here. So for Delta early on, we really didn't know the kind of impact of interventions against Delta, and particularly in somewhere like Singapore, where we've kind of had interventions all the way through. We weren't quite sure what the different interventions were doing individually as we started to lift them or not, and also of course vaccine efficacy. And then for Omicron, we've been focusing on three key uncertainties: disease severity, vaccine efficacy, and of course the transmissibility. And of course, over time, as we have more and more information coming out, we start to learn more about those, and we can focus in on what we think is the real scenarios. So what we do within the modeling framework is we try to isolate those sources of uncertainty, so as I've listed out there above, and we try to run scenarios with those different variables. So what if Omicron has this disease severity the same as Delta or less than Delta? What if the vaccine efficacy is higher or lower than Delta? What if it's 3 times more transmissible? That's quite high as an example. But those are the kind of scenarios that we're able to run, and then they're able to kind of frame our thinking around what could be happening under these different scenarios, and therefore what control measures could be put in place. So modeling can be used for a whole range of things that I've kind of described here, and the main one that I've been focusing on here is the impact of vaccination policies on transmission. But of course, that's not in isolation. We think about that in the combination with public health and social measures. And the aim that we're trying to do with all this work is understand what that means in terms of cases and ICU deaths over time. And interestingly, how over time and with different variants, we will be focusing in on different ones of those. When we're in different situations, we might be focusing on cases or ICU, and different situations lead us to be having to think of different outcomes. Modeling can help us quantify the impact of things that we're uncertain about, but very clearly modelers don't make policies, right? What we're doing in these kind of situations is we're understanding what are the possible policies that could be considered, what are the realm of possibility in terms of vaccination, in terms of control measures, and understanding simulating what we think the outcome would be under those different policy choices, given what we know about the disease and the transmission and the uncertainties there. And with this, we can do kind of both short-term and longer-term scenarios. And the sort of transition to endemicity was short to medium to long-term, and now thinking sort of longer-term, what will this end up looking like? So just a few thoughts on endemicity and on what does that mean. So actually, and the term endemicity does come from modeling in a background, and we have a very clear definition in modeling what we mean. And what we mean is that the reproduction number is 1. Right, that's what we mean when something's endemic, and what that means is that each infected individual will infect one other person. So essentially, we expect this kind of constant level of infection within our population. But of course, that's somewhat of a theoretical way of thinking about it, and it has come through a little bit more in various times to mean it can mean we can expect disease. Right, that's crudely what we mean. That every year, all the time, maybe there'll be seasonal variations, but we can kind of expect COVID to be with us for a time period. And I'm sure everybody would have kind of different definitions of endemicity. But when we think about endemicity, I think there's kind of 2 ways we can sort of think about this, and thinking about this in the modeling framework. We can think about it, okay, here are, in our endemic scenario, here are the control measures and the vaccination that we have, or the control measures that we're willing to have in place in an endemic scenario. What does that lead to in terms of cases, ICU deaths over time, and how do we deal with that as a society? And we can also kind of think of it the other way around. Okay, we're willing to, these are the levels of cases that we can tolerate in over time and in different places. What do we need to do in terms of control to kind of reach that endemic state? And I think we can think that can lead us to thinking quite concretely about what could we be put in place. And of course, we have much uncertainty. What will this look like with new variants? How does it define the response to new variants as we move forward in time? And as we had the introduction from Dr. Drtrell speaking about what does this mean for different places and different countries over time? It's the state of endemicity could mean quite different things in different places. So that's all I have for today. The modelling work that I spoke a little bit about was done by a team at the School of Public Health, working closely with colleagues at the Ministry of Health in Singapore, and we had funding from the NMRC. So thanks very much for your time today. Looking forward to the discussion later.
Thanks very much, Hannah, for that sharing. I always wish I paid more attention to maths in school, and and every time I think we reach out to medical modelers to have some certainty amidst the great uncertainty, especially at this point in time. So you sort of tantalized us, but you didn't really tell us what happened in Singapore. And I guess you're kind of hoping that Dr. Mark Ho, our next speaker, will be able to do that. And we are fortunate today to have Dr. Mark Ho, who is the Acting Director of Contact Tracing and the Epidemiology Center at the Ministry of Health, Singapore. Mark is a public health specialist by training, and prior to being thrown into the thick of things at MOH, he was seconded to the World Health Organization Health Emergencies Program, where he served as a technical lead for urban health emergency preparedness, health systems for health security, and the Universal Health and Preparedness Review. So Mark will give a talk on moving to COVID-19 resilience and the reflections from a city-state. Over to you, Mark.
Thank you very much, Liang, for the introduction. Can you see my screen? Just a quick check. Yeah. Okay. Thanks very much again. Dr. Clapham is one of our very helpful collaborators from the Salisbury Hock School of Public Health that has been very much a part of how we have been making the policies from the ministry's end as well. So it's a very nice lead in to some of the things that I'll be talking about today regarding our idea of resilience from Singapore, a city-state. As you know, we are a very small country, but very dense country. And we have certain challenges of our own, but also common challenges that are shared with other countries and cities as well. So for today, I'll be talking a bit about the journey that we've had so far, how we approached COVID, and an idea of what resilience might look like in the future as we learn from this pandemic. And finally, we'll talk a bit about how we then should move from a response frame towards recovery and preparedness for the future. So this slide basically is a summary of the experience of COVID in Singapore so far. You can see here that we had our first case in the late January of 2020, followed very quickly by a cluster, and what we call a circuit breaker, which would be in most other countries called a lockdown, where there's a substantial restricted movement. But what I wanted to point out here is that you can see that in the blue bars, the majority of cases at this time was in the dormitories of migrant workers. Now, once this was settled and things had come to a more stable state, we then entered into a phase of reopening. And after that, a phase whereby we had periods where cases will go up and we bring it down, and go up and bring it down. And we called this a phases of heightened alert. And you can see at the bottom of the text that by the end of 2020, we started to roll out our vaccination program. And this went on all the way until the end of August in 2021, whereby we had about 80% fully vaccinated as a major milestone before we started to then enter into this Delta wave, followed by the Omicron wave. And you can see the different terms that we used for the different parts of our curve as we went along. But I think importantly that the vaccination played an important decision as to when we were ready to move into this stage of considering resilience and endemicity. So we have about 300,000 cases or so. The deaths has been relatively low. And on the right-hand side of the screen, you can see that the boosters and the vaccinations have been a great part of our push to try to get our population protected. But what we wanted to do was to explain a bit as to what our strategy has been. And it's not a perfect strategy, but it was a considered strategy alongside the modelers and the inputs from the School of Public Health as well. So this is a sort of diagram that is put up by Pueyo, and you can see, many of you may have seen this, the ham and dance. So when the cases start to go up, many of the governments and agencies would then try to do things to reduce the curve, to understand the situation, to improve treatments, perhaps vaccines, get systems in order, and to reduce the pressure on healthcare systems. But once we enter into what they call the dance, it's then about ensuring that we are able to have certain activities to keep the reproductive number at a low enough level that will allow us to buy enough time to prepare ourselves for resilience. So this was really a frame that we used in the earlier part of our journey in the pandemic. And so this slide basically summarizes our thought process, moving from the response phase, the acute response phase on the left, all the way to the resilience phase where we hope to be one day. And from the top to the bottom, you would see that from testing to community measures, there's been some changes as we go along our journey. When we started with testing, it was very much PCR based, highly accurate. We've now moved towards something a bit more accessible, the antigen rapid test. And eventually one day we hope to move towards something like flu, where we do more surveillance. For treatment and recovery, we started with a hospital-centric model. We have moved towards home recovery, as well as getting the general practitioners and the primary care physicians to take up a bit more of the care. And eventually, most people hopefully will be able to self-manage. For contact tracing, we started off with extensive rings, full activity mapping. We then moved towards protecting the high risk and vulnerable persons, for example, at hospitals and nursing homes. And eventually we'll hope to move towards either very limited or even no contact tracing. For quarantine, likewise, we had facility-based quarantine. We moved to home quarantine and only doing tests before leaving the home, and eventually towards self-isolation and self-responsibility, which I'll talk a bit more about later. Finally, for community measures, we talked about the hem and dance in my earlier slide. We now have moved onwards to talking about vaccinated differentiated measures, which would then allow us to protect the vulnerable persons, but not have so much impositions on the vaccinated persons who are protected. And eventually we hope to move towards a non-intrusive sort of standard and norm. So what may resilience look like? We think that resilience would be a state whereby the healthcare system is not overwhelmed. It's able to cope with the increased demands, the ebbs and flows of the emergency, and reduce the disruptions to services, such as the non-essential services that were put aside when the first wave started to come along. We want to have enough population immunity, knowing that immunity may wane over time and there may be need for more boosters in the future. How then do we ensure that we are able to have a certain level of protection for the population? The third is to really step up this idea of social responsibility, to be able to reduce interactions when one is ill and self-test before leaving the house in persons who may have been in contact with other persons or other cases. And we are doing this in preparation for the Chinese New Year celebrations, for example, next week. We've been exhorting the population to do some of this. We think that there's going to be a bit more flexibility in working and schooling arrangements as we slowly transit towards endemicity. And we have seen how this can work with the use of information technology. And lastly, the ability to be adaptable to a virus that keeps changing. Sometimes we may need some pauses, but also to balance the social economic consequences. One of the things that we had done was to simplify our protocols. And we felt that this was important because if we have to get people to take up social responsibility, it needs to be something that is easily understandable and something that they can comply with fairly easily. And therefore, we have moved towards a 1, 2, 3 protocol, whereby 1 is for a person who is unwell, 2 is for a person who is fairly well or who has very mild symptoms, and 3 is for the person who has come into contact with a case. And furthermore, we are also trying to then reduce the impositions for vaccinated persons in living with COVID. And this is why, for example, we have now removed the need for quarantine and relied more on the antigen self-testing. But we're still learning as we go. After SARS, we built a National Center for Infectious Diseases. It was a 330-bed center with some of the public health functions under the same roof, such as a public health lab, as well as research and education. But we're still learning, for example, that in this pandemic, the role of technology has really stepped up. We now use, for example, an app-based model or tokens that are carried around, Bluetooth as a modality for contact tracing. This has allowed us to move contact tracing, for example, from 4 days to 1.5 and expanded the amount of efforts that we can do even for a very large wave. We've seen how there's a need for a whole of society approach with community mobilization. I talked a bit about the wave of dormitory migrant workers that were affected. And this really brought to mind what we need to do to ensure that there's greater resilience in these vulnerable settings as well. You can see on the picture here, it's a sitcom character, an actor that's very popular in Singapore and used to encourage people to take vaccination. So I think that the whole idea of getting our public and crisis communication in order to build trust in governments and in public health agencies will continue into the new normal. And finally, we had Omicron. And whether it's a surprise or maybe not so much a surprise, since we all knew that variants would keep coming up, it was really a threat towards our move towards resilience. And how do we then address things like this in the future? When Omicron came into Singapore, we took a more containment-like approach to better understand the situation, increase our booster uptake, and prepare our healthcare system. We increased testing for travelers. We put persons who were cases in dedicated facilities for isolation and close contacts in quarantine, also in dedicated facilities. But if you recall what we had earlier presented, what I earlier presented was a simplified, light approach, whereby a person just needs to do self-testing, there's reduced impositions. So we were running one protocol, which was very much in the mitigation mode, the endemic mode, if you may, or pre-endemic mode, if you may. And on the other hand, we're running a containment sort of protocol, whereby we're still, doing quarantine and isolation. And it was actually quite difficult because if you recall, the way in which to identify a person as having Omicron was to do the S gene target failure, which sometimes takes maybe 2 to 3 days for it to fully come out when there were large numbers of cases. And therefore, these people would then be moving from the Omicron protocol to the Delta protocol and vice versa when we started to understand which variant they were on. And it was really a difficulty for us to then say, are we really on endemic mode or are we now moving back towards containment? And eventually we did decide we know enough. We now move everybody back into our mode of transiting towards endemicity. So we do need to prepare for such future instances and surprises perhaps in the future. And one of the things that we would then need to do is to prepare ourselves for recovery and preparedness. So Singapore has been championing this idea of urban preparedness, moving from preparing not just at the global and national level, but also focusing on what it means at the at the local and the regional, sub-regional in the sense of a country levels, to then ensure that governments and people are ready to deal with the next health emergency, and to then break the momentum, the tendency to enter into the panic and forget, and to build on the momentum of Omicron, given how globalized and urbanized we are. So I think finally, where are we on this road towards endemicity? I think we are now better placed for endemicity. The road may have its ups and downs. We may move at different speeds depending on what comes at us, but it certainly cannot be a going alone type of journey. We need the citizenship as well as the citizenry as well as the global community to work together on this road to endemicity. But really, we can get some travel insurance, if you may, along this road to endemicity. We can incorporate the lessons learned. We can strengthen preparedness. We can be more resilient as we go along, both at the national and the local, as well as the global level, in preparation for us to move towards that new normal. So with that, I thank you very much again, and back to you, Leah.
Thanks very much for that talk, Mark. I'm sure many of us are trying to read the tea leaves in your slide about where Singapore is going into the near future. But thanks for sharing. But you are able to share. I see no questions in the Q&A box, and we are kind of running out of time anyway. So if any of you in the audience have questions, please feel free to email Eliza or myself or any of the speakers. But I'd like to take the opportunity to thank all the panelists who have put aside their valuable time to present to us here, and also to those of you in the audience to join us. And now in closing, I'd like to invite Professor Linkov to say a few closing remarks, followed by Dean Teo. Over to you, Professor Linkov.
Thank you so much. This was an absolutely wonderful, wonderful discussion. And actually, in my closing remarks, I want to say that I'm absolutely amazed with the low level of mortality that was just reported for Singapore from COVID-19. So I would say that one of our next seminars should be on how do you reduce mortality to such a low number, and what kind of steps we in the US should be taking to achieve the same success. So I want to say that I learned a lot from all of the presentations, and I look forward to a future collaboration. And I was absolutely amazed with such an cross and multidisciplinary look at all those things that have been discussed today, from political response to mortality to mathematical modeling to disparities. And I look forward to more events like this. And thank you so much for your time, and thank you for inviting us, and thank you for sharing your knowledge with us.
Thank you very much, Professor Linkov. Dean Teo.
Thanks very much, Liang, and to Dr. Linkov for sharing as well. I thought it's a real opportunity for us to learn about what has been happening in both sides. And while I see Mark trying to address a question by one of our participants, Wong YY, really on the Global Health Security Index, I thought the Global Health Security Index really highlighted the importance of the responsibilities that academics have, because we could put together very sound scientific responses, but equally, some of our actions may lead to hubristic responses by the government as well. And the Global Health Security Index is one that I always felt where is one of the failings that the global public health community have put in place when we started ranking countries in terms of how well or how poorly prepared they are against a pandemic, without really understanding the cultural, the context, and especially the political ability to execute some of the drawer plans. Just being able to evaluate drawer plans without understanding the implementation really highlights the problems that academics, like many of us, continue to face. Because at the end of the day, it is never just about a scientific piece of research, but really how that scientific piece of research has any bearing to real actual implementation in the real world. So it's been a real pleasure being able to hear some of the experiences from our colleagues at Duquesne University, as well as to always learn about what is currently being done at the Singapore Ministry of Health from Dr. Mark Ho, as well as from Hannah in her work advising our Singapore government from the modeling front. Thank you very much again for sharing some of the experiences. Looking forward to future discussions. So over back to you, Liang.
Thanks very much, everyone. And with that, I'd like to close this webinar. I hope we'll be able to meet in person next time. And I look forward to seeing all of you again. Have a good evening to our American colleagues, and a good day to the rest of us in Singapore.
Thank you very much. Bye-bye.